Hello, everyone. I'm Dr. David Cantor, and I will be presenting for you a presentation of some review of COVID, its impact on the brain, and some case studies regarding qEEG correlates as part of ISNR's contribution to the IOP conference. Let's start by, I want to make sure I give acknowledgement to some of my colleagues who are currently trying to help out with a project to accumulate post-COVID EEG from patients that they are currently servicing or consulting with. And also want to give recognition to Dr. Goldberg of the Lurie Neuroscience Institute, whose workshops on COVID and the brain provided some of the information and material presented in this presentation. Let's start with understanding that coronaviruses cause disease ranging from mild to lethal. There are to date 7 strains of human coronaviruses, with 4 of them leading to mild illness and 3 leading to severe or lethal illness. Okay, and this is a picture of what many of you may recognize as the coronavirus, made up of its component parts, including the spike protein on the membrane. Now, the principal symptoms that have been reported as a result of COVID infection have included principally fatigue effects such as dry cough, fatigue and dry cough, and fever. Assumption was in the early onset of the disease that this is due principally to direct damage to the lungs, but there are some researchers that have argued that the brain damage to the respiratory centers, particularly in the medulla oblongata and pons, may be occurring, which will, of course, will interfere with the nervous system's control over breathing. Now known to affect the central nervous system, the virus contributes to effects on the central nervous system directly and indirectly. And there are other end organs that can be affected, not just the lungs, but there's evidence to show that the kidneys are impacted. Certainly the blood is impacted in terms of blood supply to regions of the body, and also aspects of the digestive system are affected by this viral infection. In terms of its influence on brain function, there are 2 general pathways thought to be involved here. One is a more direct pathway, that is that through the blood, the virus is being carried in the cells in the blood, and obviously can then get access to brain cells. So there's a hematogenous pathway, if you will, to brain cells. There's also a sort of transsynaptic transmission along the axons, from the olfactory nerve, as we'll see in a minute, to the cranial nerves. And this kind of pathway of axon to axon transmission of a virus has already been discussed and reviewed in evidence in other viral infections. And so it's argued that no less should be true in this viral infection process. It's thought that the virus enters the cells, the brain cells, through the ACE2 receptors that are on many brain cells throughout the central nervous system. Certainly, while that may be some of the direct invasion or infection pathways directly into brain cells, there is effect on brain function, which is thought to be at least the result of indirect mechanisms. Principal among those are various types of inflammatory processes that have been evidenced or discussed. And these inflammatory processes after infection have been known to persist for at least 3 months post-infection. There are other indirect effects that feed back. Some of the individuals are reporting secondary syndromes such as Guillain-Barré, which is a secondary effect of inflammatory mechanisms. Whitaker has argued that there may be a demyelinization process taking place that's secondary to free radicals potential distributed as a result of an inflammatory process. And for children in particular, there's an argument that we're seeing certainly a similar kind of profile as Kawasaki Syndrome, which is an autoimmune type of, or an immune system dysfunction that impacts on children's behavior and functioning. One might argue that there is an organ feedback via the vagus nerve or demyelinization of the vagus nerve tracts from peripheral organs to the central nervous system and back. And we'll talk a little bit more later on, but when that occurs, you can get a dysregulation of end organ functioning as a result of false feedback information being sent to the brain and then forward feedback from the brain back to the end organs. So it's a disconnect, if you will, of information between sensory nerves from the periphery part of the body to the brain. Now, it's thought to believe that the virus's primary point of entry is through the nasal cavity. The virus enters into the nasal cavity, infects the olfactory nerves, then traveling into the olfactory tract. And then, as I mentioned, it's thought to then propagate from the olfactory tract and cells into deeper areas of the brain. There are indications of the mechanisms of COVID on the brain in general. As I've already mentioned, there is this potential retrograde invasion of the brain along the axons themselves. So there's a progressive generating of the cell-to-cell spread of the virus. The virus can also potentially be crossing at the blood-brain barrier from the vascular system into the brain cells and surrounding cellular areas. There are indications that secondary to the nature of the way the virus works and its impact on systemic functioning, that we get hypercoagulation leading to either ischemia, some form of ischemia, and CVAs that are occurring, which of course can lead to cellular death in the brain. There is the argument, as I've already mentioned, a potential autoimmune response type of mechanism leading to demyelination, which will of course impair cognitive efficiency, if you will. There is, secondary to the impact on respiratory and oxygen availability to the system, hypoxic injuries. And we know that hypoxic injuries can lead to certain levels of encephalopathy. And then, as I've already alluded to, when the immune system is reacting to any kind of foreign invasion, you get an activation of cytokines. Some of these cytokines are pro-inflammatory, and pro-inflammatory cytokines can attack the microglia in the brain and then, in a secondary sense, affect brain functioning efficiency. So there is a question, can this virus really invade brain cells? There is some preliminary work that has been done at Johns Hopkins University where they've explored the potential of or examined the viral infection into what they call mini brains. These are neuronal balls that are created from human stem cells. And in fact, they noticed that, yes, indeed, the virus can infect the mini brains through the ACE2 protein receptors, as we mentioned. And then once the virus gets into the cell, this is how viruses propagate. They spread, they multiply, and some of the data indicated that within 3 days, the number of copies of the virus noted in these examinations have increased tenfold. So whether or not it's passing the barrier as described here, or again, secondary to inflammatory processes, or a little of both, is still not clear, but there seems to be some preliminary indications that it's probably a little of both. So the stages of the what we now call neuro-COVID effect is first, principally the virus binds to cells in the nasal passage, as I described. One of the common symptoms immediately noticed is that you begin to have a reduced sense of smell and taste, which many, many patients report. It can lead to these cytokine storms, either on a mild level or on a more severe level, which, as I mentioned, can lead to vascular inflammation, coagulation, and eventually to cell death, which may induce either coma or delirium, as reported in a number of cases. Generally speaking, cytokines and the receptors are distributed throughout the brain and known to influence neural development, synaptic transmission, behavioral traits, and have been implicated in other neuropsychiatric disorders such as autism and schizophrenia. So we know that cytokines do play a role in at least inducing, if not inducing, certainly exacerbating factors of neuropsychiatric symptoms. In the case of COVID, because of its nature of principal travel in through the nasal cavities and infecting frontal areas and spreading inward, and also influencing temporal areas, frontotemporal and temporal areas, the three primary areas of suspected impact are the mesial temporal lobe, potentially or reaching down into the hippocampus, certainly the frontal lobes, and as I mentioned earlier, there are some that propose that there's impact as deep as into the brainstem area. In some summary of the data to date that was posted in February of 2021, in terms of the long-term COVID effects, I don't have a lot of data on children yet, obviously, but in the preliminary data on adults, there seems to be an increasing number of reports to say that, at least for a number of individuals, there are longstanding effects, and that in one cohort study, they showed that 76% of adults reported at least one persistent symptom as much as 6 months after their infection. More than 50% of the children that have been studied so far had at least one symptom that persisted 4 months or longer after their diagnosis, and about a quarter of those had 3 or more symptoms. So although the patients were symptomatic and hospitalized during the acute infection, of course, they're more likely to show persistent problems. But even some of the children who initially presented as asymptomatic, at least in the acute phase, ended up showing or evidencing or reporting symptoms several months later as a delayed effect, if you will. And in some studies, they talk about this long-term effect occurring in 42% of those that had these persistent symptoms, said that the symptoms were severe enough that they interfered with everyday life. So there's a growing body of evidence to suggest that there are long-term effects of what we're now calling neuro-COVID. As I said, the neurons in general have significant levels of these ACE2 receptors, which actually allows the virus to penetrate them. And therefore, once the virus gets into the cell, it disrupts mitochondrial and protein folding and activity. This eventually, at least arguably, when it spreads across so many cells, potentiates the vulnerability to a degenerative disease, which may occur at much later stages, months, probably even years, after the acute illness appears to have dissipated. Now, among the neuroimaging and neuropsychological findings to date, there are some studies that indicated that as much as 84% showed signs of neurologic symptoms from COVID, which includes encephalopathy and cortical spinal dysfunction. At the point of discharge after acute treatment, 33% reported or indicated dysexecutive syndrome. That's an inability to carry out executive functioning efficiently. May even show ADHD symptoms, and in some cases, even poor coordination of movement. There are some studies that describe EEG disorganization, which might be a measure of coherence, and the MRI studies show some hyperperfusion. Again, this is all findings principally noted in the frontotemporal regions, which I described earlier are the regions of interest that are more likely to be impacted by the COVID infection. And in fact, neuroimaging studies have shown this to be involved, particularly with acute ischemia occurring in frontotemporal regions. There are a variety of studies that now are reporting a variety of neuropsychological symptoms post-COVID, which includes everything from attention problems and working memory to what is often described as brain fog. Some of these studies were examining large databases, and the incidence rates of these kind of reports generally are increasing in populations in the United Kingdom and also in the Italian population. Oftentimes, these symptoms are being identified within 3 months post-recovery. So again, there's a sustainability of these symptoms. And they're as high as 87% reported, for example, in the studies on the Italian population. When some very specific matching control studies have done between COVID patients and matched controls, indeed, the post-COVID patients are showing significantly more performance on continuous performance tests of attention. And that has a very positive correlation to the degree of inflammatory mechanisms as measured by C-reactive proteins and reaction time in the patients. So in general, the psychiatric and psychological symptoms include these sort of brain fog type of confusion, memory impairment, sometimes depression, fatigue, changes in sleep or sleep disruption. In one study that screened about 359 children and over 3,000 teenagers in China, approximately 22% showed elevated anxiety and depression compared to only 13% prior to the pandemic. It's not clear to what extent this is a reaction in terms of changes of emotional regulation or reactivity to the stressors in everyday life in general that the pandemic did, or again, if there is a factor that influences a predisposition to having emotional discontrol as a direct infection or impact on brain functioning. As I mentioned earlier, the vagus nerve is of some interest in some of this ongoing research. We know that the vagus nerve has many, many types of sensory neurons that pick up changes in activity in end organ systems that sends those signals back to principally the rostral insula area and other areas deeper in the brain. The rostral insula, however, plays an important role in also regulating emotions. So as changes occur in peripheral organs, and there becomes a dysregulation or communication between end organ systems and the brain, it's thought that you get insula functioning that becomes dysregulated, and that may, in a sort of secondary sense, impact on emotional regulation networks as well. More needs to be done to validate or verify some of the theoretical underpinnings of that set of circuits and the relationship between end organ functioning and central nervous system involvement in the regulation or feedback in those end organ system functioning. There has been more recently a question about the role of now the increasing use of the vaccines and maybe some toxic effects from the vaccine. This is highly controversial. We do know that the vaccines, the way the mRNA vaccines certainly work, is to produce a toxic protein. These are prion proteins that stimulate, if you will, the immune system to produce antibodies or become, in a sense, generating ways to fight the virus. However, the increased proliferation of these toxic prion proteins that are produced by the messenger RNA are raising questions about how this may affect other end organ accumulation of these toxic proteins, and in the long run, what this might lead to in terms of its impact on neurodegenerative diseases. Again, increasing vulnerability or susceptibility to such processes. Again, a lot of information is just not known about the potential long-term, but theoretically, there are risks being argued here. So basically, the SARS spike protein binds the ACE receptor on the platelets. This can eventually affect and improve changes in intravascular coagulation, either to increase it, so you get coagulation, hypercoagulation, or you can get low platelet count and therefore a lack of proper clotting. And in the case, you may see increased bruising or hemorrhaging. Either way, you're potentiating a vascular contribution at the level of the brain to impact cell death or certainly areas of the brain's ability to function properly. And so again, there is this toxicity concern of the prion proteins that are involved in this form of vaccination. There are charts that are in the handout. I'm not going to go through on the different types of vaccines, but you can review this in terms of their development, what's involved, what they have found in terms of effectiveness, what's actually in some of these vaccines, what's their level of evidence to indicate a protective effect, but also what are some adverse functions. And some of the adverse functions, again, have to do with immune system functioning, Bell's palsy, other things that do raise some concern that may occur in the population. And there are a whole lot of questions still outstanding about the general effectiveness and potential risks of these vaccines in the long term, a lot that we simply do not know. So I would encourage you to review these slides when you get a chance to take into consideration that there's a lot we don't know about the vaccines that at least some people have raised concerns. There is, excuse me, with any kind of vaccination program, it's been well known that there are individuals in the population who are likely to have adverse effects. And this now includes COVID-19 vaccines. It's already recognized by the government. There's likely to be at least some individuals that have strong adverse reactions that produce measures that warrant compensation for damage or injury. So the very fact that this is recognized that it can happen, even though if we don't know the incidence rates yet, is again raising concern. Let me quickly illustrate a couple of case studies. And again, we're still trying to accumulate data to get more group work, but in case one, we have an older individual who came in pre-COVID, who had concerns about some general cognitive functioning, which included aspects of attention, mental flexibility, decision-making. Again, not that it impacted hugely on his day-to-day performance or capabilities, but he noticed a decline relative to what he felt he had previously been experiencing. And we looked at those measures relative to other aspects of his cognitive ability, such as IQ. And there are areas that are relatively weak, and he was seeking to use a form of neurofeedback therapy to somehow improve or optimize performance. And he underwent that after getting qEEG data and results, and felt that there was improvement, and the improvement was documented by computerized testing of performance measures, which I'll show you in a minute. However, after he completed that course of intervention, late summer of 2020, he experienced about 3 weeks of a COVID-like infection, became concerned that there was slippage in his cognitive abilities resulting from that experience, and they continued to persist for at least 3 months in a way that we would describe brain fog. And so he came back to the clinic with that concern. We did qEEG brain mapping, and this shows you the dates of the evaluation. In particular, on time point 4, this is the post-COVID, set of maps compared to time point 3, which is a set of maps that showed the relative improvement in a number of areas of measurement following a course of neurofeedback program. And you can see a regression in terms of increased deviation of functioning in the delta and theta bands following the COVID infection. He then pursued another course of home-based neurofeedback therapy. And as you can see, as of the December of 2020, following several weeks of that intervention, we saw a restoration of improved brain functioning, which corresponded to improvement in computerized continuous performance tests. You can see on line 4 here, there was some decline after 90 days post-illness in some areas of cognitive functioning, not a significant decline, but a trending in that direction in many of these areas. However, there was a significant restoration of performance following a course of neurofeedback therapy, about 10 hours worth, as you can see on the bottom line of the computerized test results. We looked at a mitochondrial disorder in a 16-year-old who had been having mostly problems with affect regulation secondary to his mitochondrial disorder. We utilized a 3-month program using photobiomodulation. He showed improved stabilization and general energy. But when he got infected with the COVID, after 3 months later, he became increasingly more anxious. He was impacting on his schoolwork. He was shutting down on performance. During that 3-month period, we did a follow-up brain functional assessment within 45 days post-infection. And indeed, these are S-Loretta, 3-dimensional neuroimaging. And the last 2 images that you're seeing in here are the images following the COVID infection. You can see the number of voxels showing significant deviation and reduced activity in a narrow band of beta, principally impacting on the post-cingulate gyrus and precuneus area. And the number of voxels increased in terms of deviation post-COVID, while all other conditions of his treatment, which, by the way, he was utilizing Prozac throughout, it had not changed. So this strongly indicated a change in and a deviation of functioning that may be correlated to his change in mood regulation. The number of voxels exceeding 2 Z-scores in the infratemporal frontal regions, the insula and parahippocampal areas, particularly in theta, that were deviant, increased during the post-COVID period. And lastly, a case of pre and post-vaccination with a 48-year-old male who we then looked at pre and post-vaccination. You can see not a lot of big changes here in the topographic map results of the individual. Although, if you look carefully, you will see some changes in, of course, the relative delta and some changes in alpha, principally in frontal regions, and some increased activity in beta 2 in absolute power as a result of post-COVID, or noted from post-vaccination, not COVID, I'm sorry, post-vaccination. And we look at the S-Loretta in this case. Again, the S-Loretta shows pre-vaccination, where there is some deviations in a narrow band of alpha, but none in the frontal regions that are noted. However, following vaccination, frontal region dysfunction is now becoming to be noticed, principally in the medial frontal gyrus, which is an area of concern as we raised earlier. And the number of voxels increased from the pre-state from 14% to over 21% voxels now deviating from normal, with a maximum deviation in the frontal region of over 2.4 standard deviations from normal of overactivity. The area in the posterior region, which was there pre-morbidly, also did not change in terms of the magnitude of deviation. So the deviation in this pre and post-vaccination case was principally in the frontal region, as might be suspected of influences of inflammatory processes following vaccination. The changes in cognitive functioning measured by computerized cognitive functioning using the Cambridge Brain Science measures did not show a lot of significant changes in any of the areas of general cognitive functioning and executive functioning measured by that instrument pre and post. The conclusions we can have from this research and some of the findings to date is, while it's still in its early stages, there's a growing body of evidence that suggests that the SARS-2 COVID virus does influence brain function in adverse ways, both directly and indirect ways that we can potentially examine and further explore. There are as would be expected, neuroinflammatory processes that can lead to decreased attention and brain fog type of conditions. Again, either directly or indirectly, also contributing to increased elevation of anxiety and mood changes. The durability of those symptoms post-COVID seems to be varied and seems to be somewhat idiosyncratic, with the residuals of infection can lead to or interfere with premorbid and ongoing treatment. And as much as vaccines can create similar immune-mediated reactions, there's now concern about, at least for some individuals, what that might mean in terms of a vaccine-induced cytokine storms or other similar symptoms that can then lead to post-vaccination effects, at least for some period of time. Still open to be explored and further understood is whether neurotherapies that include traditional operant conditioning neurofeedback therapy or photobiomodulation techniques, and possibly the utilization of the new anti-inflammatory agents that are beginning to be explored may in fact operate at the level of cell receptors that provide some sort of protective or treatment effects on brain function. Thank you very much for your attention on this quick overview of potential contributions or effects of the COVID virus on brain function and some qEEG correlates in some early case studies. I will make myself available for questions at a later point in time. Thank you very much.
Good day, everyone. My name is Dr. Roger DeBuse from the University of North Carolina at Asheville and the Neurofeedback Cooperative Group. Also with the IS&I group here today. Today I will be presenting on neurofeedback for ADHD, looking at the evidence base and the results of a large randomized clinical trial. As far as disclosures financially, I've received research support from NIMH, in-kind neurofeedback hardware support from Thought Technology and Brainmaster, in-kind software support from Eeg for the neurofeedback software, and BrainTrain for the IVAS CPT. My non-financial conflicts include being past president of the board of the International Societies of Neuromodulation Research and current member of the Foundation for Neurofeedback and Neuromodulation Research. So for today's learning objectives, we want to understand the hypothesized mechanism of neurofeedback training to improve cognitive and behavioral performance by modifying abnormal EEG waves. We're going to discuss the meta-analysis of published randomized controlled trials of neurofeedback for ADHD. Describe how previous studies are flawed to detect a specific effect of neurofeedback beyond the non-specific benefit of many contacts and concerted efforts. And then we want to learn the preliminary results of an NIH-funded, double-blind, placebo-controlled, randomized clinical trial of neurofeedback for ADHD. So the theory of neurofeedback basically is that EEG power in ADHD children differs from normals in certain bands. For example, one of the more popular ones is too much theta, which is 48 cycles per second, and too little beta, 13 to 21. And so therefore, the idea is to train these deviant bands back to normal. So if we have too much theta, we would train that down, too little beta, train that up, vice versa. And the most popular protocols are theta-beta ratio, sensory motor rhythm, which is 12 to 15 over the sensory motor strip, and slow cortical potential training with ADHD children. So we have many randomized trials, but have been somewhat inconclusive. Usually there's imperfect control groups and the positive RCTs using unblinded wait lists, suboptimal treatment and negative RCTs using small samples, and then there's unstandardized treatment. And then of course all this creates some kind of controversy. So what we ended up doing was got a group of professionals together in the different fields because, as a neurofeedback provider, we always criticized, oh, look at these guys getting funding, and they don't know anything about neurofeedback. And then, of course, when the neurofeedback people apply for funding, we get told that, oh, you don't have enough research experience to make sure that you do a good job here. So a group of us got together many years ago, 6, 7 years ago probably, at a CHAD meeting. And so we decided to get together a group of neurofeedback experts, clinical trials experts, statistical experts, ADHD experts, in the hope of addressing the flaws of the previous studies and finally coming together and saying, here's a study that we can all agree upon and hopefully do the right thing. So some of the flaws that we addressed in this study was the sample size. We had 142. Also the sham placebo. We used a sham of equal duration, intensity, frequency, and likelihood of reinforcements by using pre-recorded EEGs. Lack of blinding. All participants, parents, teachers, and trainers and investigators are blinded. And also research domain criteria. We used the EEG TBR ratio of greater than or equal to 4.5 at FC or CZ, which was required for the study entry. And as you all may know, most studies don't require an EEG marker to get in. You just need to require ADHD, but we did the EEG marker as well. Another thing that we addressed was lack of testing of blind validity. We collected blinding information from children, parents, and trainers after they completed the training, and to identify which condition they were in or felt that they were in. We also looked at tracked and monitored medications, psychotherapy, and educational interventions. We did not allow psychosocial treatment, and we had 3 follow-ups at 6 months, 13, and 25 months. And we set those up to be consistent with the multimodal treatment of ADHD study. The other thing we did is we used pharma-like safety monitoring and adverse event tracking, monitoring AEs weekly, as well as having weekly clinical panels of the progress, treatment, etc. We also standardized our training site to either CZ or FC, inhibiting theta, rewarding beta, 38 sessions, systematic session lengthening 25 to 45 minutes, 3 times a week, 13 weeks. And we had fidelity monitoring of our treatment, which we reviewed with session videos. Every child was recorded during all their sessions, when you can see both the child and the trainer, so we can get feedback and training as well as having site visits. So our study design consisted of a 2-site parallel group, double-blind, randomized comparison of active to controlled neurofeedback. We had 142 boys and girls ages 7 to 10. They were rigorously diagnosed with ADHD, both categorically and dimensionally. Randomization consisted of 3 to 2, which ended up being 84 active and 58 sham, in blocks of 5, balanced on current ADHD medication. And all staff with participant contact did not know the condition the child was in. So our inclusion-exclusion process was sequential. So we basically did it over the course of at least 2 sessions, if not more. We conducted a structured interview using the CHIPS with both the parent and the child. Also, they had to get a T-score rating of 65 or greater on the Conor's DSM-5 ADHD inattentive criteria by both parent and teacher. And then the theta-beta ratio had to be greater than or equal to 4.5 at CZ or FC in the eyes open condition. And whichever one was greater also identified the training site. IQ greater than or equal to 80. Vitamin D in the normal range, greater than 30. And if they were low on the vitamin D, they got supplemented, and they would come back in a month, and we'd do a blood draw and see if they improved. And once they did, we'd move forward. Excuse me. For exclusion, we did not allow comorbid disorders requiring psychoactive meds other than a stimulant. No alpha-2 agonists as primary ADHD meds, so Capbay and Tuna of guanfacine. If they were on that as their only ADHD medication, we did not allow them in the study, because the point of all our assessments was to conduct them medication-free, and with the alpha agonist, it takes several weeks to titrate it and get it out of the system, and so that would have been too much work. And so that's one of the reasons why we did that. Anyway, medical disorder requiring confounding medications. If the child had sleep apnea, restless legs, plans to move, antipsychotic in the past 6 months, fluoxetine, or other psych meds in the previous 2 weeks, all excluded, and also if they had more than 5 neurofeedback sessions. Second set of exclusion, concomitant psychosocial treatment not allowed. We also had medical EEG reviews indicating abnormalities, so every brain maps, qEEG, EEG that we did in the beginning was sent off to a neurologist, reviewed for abnormal activity. If there was any abnormal activity found, we would send to the local neurologist and have the child treated accordingly. And if everything came back after visiting the local neurologist was normal, within normal limits, we move forward with them in the study. I already said that about vitamin D. Supplementation until back to normal. Convergence insufficiency is another exclusion. Convergence is sort of going from far to near, like looking up at a chalkboard, looking down at your desk. If you have a hard time refocusing after you do that, you start to get behind a little bit. And then, of course, it starts to look like you have an attention problem. It impacts your ability to pay attention because your eyes have a tough time shifting. And if they were taking stimulants, they were allowed to continue except 5-day washout for each major assessment point, typically at least 2 days during the school. So for the blinding, the control children got feedback from pre-recorded de-artifacted EEGs of children who had actual neurofeedback. And then, as I said, the muscle artifact of the live child overlaid to keep experienced neurofeedback trainers blind. And it's sort of like a poor person's EMG biofeedback because basically you did get feedback on if you had too much muscle artifact, you would not get the feedback like you do in regular neurofeedback. And so it's similar to real neurofeedback because you got some feedback. All right, so to compare the treatments that we used, both conditions got coaching, inhibiting movement, inhibiting muscle artifact. And then also we gave money points, nutritional counseling, and sleep hygiene. And the only difference between the two groups is the real neurofeedback group got contingent reward beta and contingent inhibiting theta. So that's what differentiated the two groups. That's those small little things. Well, not small. Here's a consort chart. We screened 329. Of those, 305 met the ADHD diagnosis. Of those, 235 had a TBR that met criteria, about 80–90%-ish. And of those ended up being randomized at a 3-to-2. We had 144. And we treatment, we had mid-session. By session 20, we were down to 84 and 58. And end of treatment, we were down to 82 and 55. And for the 13-month follow-up, we were down to 74 and 54. So the mean age of our participants was 8.4 years old, 78% male, 76% white non-Hispanics, 8% African American, 4% Asian, 13% Hispanic. Almost half received special education services. Our household income was basically pretty much on the higher side, a quarter below 50,000, and 44% 50 to 100, and a third greater than 100. Parent education, same kind of profile. 8% high school diploma, 21% up to 2 years of college, 39% college grad, advanced grad almost a third as well. So again, mostly money-making parents, higher SES, and professional parents. So to start off with our clinical profiles here, for the CHIPS, we had the structured clinical interview. 51 of our children were qualified for an inattentive diagnosis, and 91 qualified for combined diagnosis. And of those, 69% had comorbidity. 50% oppositional defiant disorder, and 21% an internalizing disorder. And these numbers are pretty consistent with the literature. And then for our baseline Connor's 3 ADHD scale item means for inattentive, we had a 2.1 for parent, 2.0 for teacher, and that was our primary outcome. And 1.5 or above is considered clinically significant. For hyperactivity, 1.9 and 1.7. Of note, about 29% were taking stimulants, 31% in the control group, and 27% in the feedback. And the way we looked at treatment fidelity is rated by both the trainers and an independent rater, Vince Monastra. And he watched, like I said, he watched session videos. And Heron scores range from 0 to 100%. And according to Vince, we had about 93% adhere to the treatment protocol and the training parameters, while the trainers rated themselves a little bit better, almost 99%. So when we looked at the blinding and the guesses about assignment, um, the unsure was about 40% average, which was interesting, and then the correct was 34, 32, and 39%, with a 35% average. So about a third overall correctly guessed, and about a quarter incorrectly guessed. And of the control group who guessed correctly, the parents and the trainers are more likely than the child to figure that out with a 19% average. So what this means is basically that we were successful in the blinding technology, that you know, we were able to convince everyone or fool everyone, or whatever you want to say it, that they couldn't figure out which condition they were in. So we were successful with blinding. So some of the adverse events that we had, pretty consistent between both groups. We have the different domains of AEs to the left there, control and neurofeedback column. And in the end, headaches, irritability, and oppositionality had the highest overall events of 9.8%. And these refer to the number of subjects with AEs, not the AE counts per se. So some of the hypotheses we looked at. First one was children randomly assigned to neurofeedback will, when assessed in an unmedicated state, show significantly greater reduction of inattentive ADHD symptoms and better functioning rated by parents and teachers than those assigned to the control group. For hypothesis 2, the children who learn to manipulate their theta brainwaves will have a significantly greater reduction of inattentive ADHD symptoms compared to children who do not learn. Hypothesis 3, at 1-year follow-up, children who receive neurofeedback will have greater reduction of inattentive symptoms and better functioning than the control group when assessed in an unmedicated state. And here we have the primary outcome measure, the Conor's ADHD rating scales, inattentive. We have both composite, combined parent, and teacher ratings. And as you see to the left here is the scale, and then 1.5 is considered clinical. And the bottom we have baseline session 20 and session 40. As we can see, from baseline to session 20, we had significant improvement for the neurofeedback group with parent, teacher, and on the composite, and it seemed to level out a little bit going towards session 40. And for the CGI-I, which is Clinical Global Impressions Improvement category of 1 or 2, we had about 60% classified as responders. Now, when we look at both groups, we still see a large pre and post effect for both the control and neurofeedback group. You can see on this chart here, the green is the neurofeedback, red is control, and both groups have a similar pattern of improving significantly between baseline and session 20, then leveling out a little bit by session 40. And the CGI improvement, 60% improved in the neurofeedback group, 53% improved in the control group. And this was a surprise to everybody on the team as well. Now, when we look at the comparison to the MTA study, the composite parent-teacher rating of inattention, we see that the neurofeedback group in red improved compared to the MTA behavior management, same kind of pattern, improving from baseline to mid-treatment to end of treatment. And the MTA medication, intensive medication management, which I think they almost met weekly with their medication prescriber, improved a lot better than both groups. So our neurofeedback outcome is consistent with the MTA behavioral outcomes, which was much longer and much more expensive and much more intensive than the neurofeedback. And then we look at pre and post effect sizes compared to the MTA study. For the neurofeedback group, the parent ratings are obviously very good, and the teachers not so much so, but very close, medium effect sizes. And then overall, we had about a 1.0 effect size, and remember, 0.8 is large. And for the MTA behavioral, parent and teacher was rated much higher, And two, the thing to remember about the MTA behavioral intervention was that it actually included teacher training on how to manage ADHD kids. And for the behavioral management, medication management for the MTA was significant, much better than um, the neurofeedback intervention. But again, the ICANN groups seem to get pretty close to the MTA behavioral intervention. And here we take a look at the theta-beta ratio learners, looking at the control group versus the neurofeedback group. Controls are in blue, neurofeedback in orange. And we see a much better learning slope per se, because as sessions across time, they're much more successful at reducing their theta-beta ratio versus the control group. Starting in 2013, Sanuga, Bark, and Cortese and company did some meta-analyses, and one of the premises of their articles was that the most proximal raters, usually parents, have an invested interest in outcomes, so therefore, of course, they're going to rate improvement in children versus the teachers, who are most likely probably blind because they don't have to go to the sessions and they don't have as much investment for the outcomes, are probably better blinded raters. And so therefore, one of the things they posited was that most of the neurofeedback studies rely on parents' ratings, which indicate, that there's a bias going on because, of course, if you're going to spend all that time bringing your child to 20 or 40 sessions, of course you're vested in the outcome. And so as we see, in 2013, there was only 8 studies with the parents that was significant, and then 0 for the teachers. 4 for the teachers. 2016, it got a little bit better, except the effect size went down. And also in 2018, now finally we have significance for both parent and teacher. And then what we did is we added our study, the ICANN study, and now we still have a medium, small effect size for the parent rating as well as the teacher ratings, but it is significant after treatment. So now let's look at the 13-month follow-ups. So approximately 9 to 10 months after the end of the 3 or 4 month treatment is when this occurred. This is analogous to the MTA 24-month follow-up after end of 14-month treatment. So same time lapse from end of treatment. We wanted to try to do some kind of close comparisons as far as that went. And so of interest, we had a very high retention rate of 90% for a 13-month follow-up. 128 showed up out of 142, 74 out of 84, and 54 out of 58. So now we look at the neurofeedback versus control group from baseline to 13-month. We see that the control group continued to sort of stay plateaued from end of treatment to 13-month follow-up, while the neurofeedback group bumped up a little bit and came back down. But at the end, we had the difference of the 13-month follow-up was a Cohen's of 0.35, but this was not significant. And then we compare to the MTA. Same thing as we did before, except this time, as we see with the MTA, the medication management came right back up to consistent with the MTA behavioral as well as our neurofeedback intervention. So that was an interesting metric there. So in this slide, we're looking at effect size and remission comparisons. Remission is basically the combined inattentive and hyperactive impulsive scales with a metric of 1 or less. And so here on the left side, we have neurofeedback studies. On the right, we have the MTA trial. And we see the effect size, we consider large effect size as 0.8. So when we look at the ICANN study, we have with the neurofeedback group, it's pretty high effect sizes. Even the control group has high effect sizes. But the remission rates are about twice as much for the neurofeedback group compared to the control group. And an interesting pattern with the pre-post to pre-follow-up. It's sort of flipped, went in opposite directions. And once again, these comparisons are similar to the behavioral treatment arm of the MTA study. And the remission rate, we look at this, looking at the control and the neurofeedback groups, and we see a significant difference by 13-month. However, when we did a sensitivity analysis, and in the beginning the groups were 0.14 apart, so we took that difference out, and then after doing that sensitivity, there's not a significant difference with remission rate, looking at it that way, although the numbers look like they doubled, 18.5% in control and almost 40% in the neurofeedback group remitted their diagnoses. Very impressive. And changes in medication, so what we looked at is less needed, unchanged, or more needed. And the differences started showing up in the baseline to 13-month follow-up, because basically from the baseline to the end of treatment, we asked them not to change their medications or their dosages as much as possible, if at all possible. And so the difference is less needed. Neurofeedback almost doubled that of the control group, and then more needed, same kind of pattern, almost double that of the control needed, twice as much controls needed increased medication than the neurofeedback group. That was significant. And then also at the end of treatment to 13 months, similar kind of pattern where the control group needed more medication and the neurofeedback needed less medication. Now we tried to look at to see if session rewards made a difference or not. We gave money points, and that was not different between the two groups. Rewards per minute, well, that was not significantly different between the two groups, although it looks like neurofeedback got a little bit more. We looked at the incorrect reward percent, the incidental reward percent, and as far as the TBR learners go, 59% in the control learned, 67% in the neurofeedback learned, although that was significantly different. But we still had a decent amount, more than half learned in the control group how to change their TBR. So there's not much here showing other than there's not much here showing that the rewards made a difference. So in this slide we see that comorbidity moderates response, and so this came from the CHIPS in the beginning when we identified different comorbid disorders. So either externalizing includes oppositional and conduct disorder, so to speak. Internalizing includes anxiety and depression, but it was mostly anxiety. So the groups either had both internalizing and externalizing, one or the other, or neither, along with their ADHD. And on this graph here, the solid lines are neurofeedback, dotted lines are control group. And then what we see, some of the interesting findings was that for the control group, the purple dotted line, control group internalizing only, they did very well and sort of maintained that over the 13-month, while the externalizing only group, or neither group for the neurofeedback group, who had neither comorbid diagnoses, did much better overall. So some really interesting findings. So we did find a group by time by treatment interaction there with the different comorbidities. So, and this obviously reverses the treatment superiority with the internalizing anxiety control better than neurofeedback, significant at treatment end. With externalizing, neurofeedback was better than control at the 13-month follow-up. So basically don't give TBR neurofeedback to those with anxiety unless they also have disruptive behavioral disorders, which was really interesting because most of the time we think that oppositional kids are tough to deal with. So in summary, results only apply to theta-beta neurofeedback. Both neurofeedback and control had large pre and post effect comparable to the MTA behavioral treatment at treatment end. Non-specific effects are obviously strong and lasting. From primary outcome at treatment end cannot conclude a significant specific effect of deliberate contingent reinforcement of decreased theta power and increased beta power. We also see that comorbidities moderate the outcome. The comorbid anxiety without disruptive behavior disorder is contraindicated for TBR neurofeedback. And we're seeing differences beginning to emerge at follow-up. There appears to be a delayed benefit. So for example, at 13-month follow-up remission rate of neurofeedback group is twice that of the controls, similar kind of pattern with less medication. The effects are apparently as good as the longer, more expensive and intensive MTA behavioral treatment. The control group needs further study for clues to identify the active components of the treatment package. And so finally, we're still puzzled about what made the control so effective. Did we identify a sample with good prognosis? Was it really that the artifact suppression, EMG biofeedback approach really taught them to regulate, pay attention, and that was enough to really help them? Intermittent incidental reinforcement may have been something there. Supportive coaching. We spent a lot of time coaching our kids, probably more so than most. I think that made a big difference. Practice exposure to uninteresting screen with response prevention. Quality time and relationship building. Again, the coaching, constantly focusing on how to get better, how to improve what they're doing, etc. We also paid attention to nutrition and sleep hygiene. And perhaps it was the powerful sci-fi props. It was a super placebo. Just come into my lab and you will get better. Is it necessary for the child to believe in it for it to work? Obviously, we think so. So in conclusion, I thank you very much for your time. If anybody has any questions, feel free to contact me at rdebuse@unca.edu. I hope you all enjoyed this presentation. Thank you.
Hello, everybody. My name is Dr. Einat Rogel, and I will present the third part of ISNR trilogy. My presentation is going to be about the impact of neurofeedback on children and adults with developmental trauma, results of 2 random control studies. I would first like to acknowledge everybody who contributed to the 2 studies, and you can see that it was a huge operation. Our presentation is going to start with motivation and why would we like to incorporate neurofeedback when we work with people with developmental trauma. We will talk about developmental trauma, so we will all be on the same baseline. Then we will talk about the adult and child studies, and we will finish with a discussion. So let's start with motivation. These caregiver testimonies were given by caregiver of the participants in the child studies. They can show us what are the reasons that parents are seeking for help for their children, and also when they're adults with their developmental trauma. So the first caregiver is talking about the child who cannot solve the problems, even though the directions are simple and clear, and they still can't do it. The second caregiver, who adopted 3 children, talked about the emotion regulations, that the kids are getting triggered easily, they get mad, cry, and they keep fighting, and they can't really keep any parts of the body to themselves. The last testimony was given by a caregiver of an adopted girl in school. And this was like, she's spacey, she can't focus, she's failing her classes. Both us and the teachers were talking to her, but nothing was helping. So when we see this behavior and what is going on with them, a common response from the environment is, what's wrong with these children? And we know that the answer is they have developmental trauma. It's not that they want to, it's not that they don't care, they just cannot. So what are the options for these children? According to one of the testimonies is every time there's an incident, the child has to be put on medications or to find a new school. Another one was talking about the many diagnoses that the adopted daughter had. And this is ADHD, anxiety, depression, bipolar, psychosis. And she was on more than 1 medication, even when she was 6 or 7 years old for all these conditions. And the other person talked about, we tried all options. We tried everything. Nothing was working. And this is for us is why we would like to think about incorporating neurofeedback into the treatment. So let's go and talk about developmental trauma. And before we talk about what it is, we'll talk what developmental is not. Developmental trauma is not a diagnostic, and it's also not a PTSD. A PTSD, what we would say is that there's a baseline before, there was a traumatic and danger incident, and the situation after the incident was not the same as before. And the person cannot overcome the incident and keep living there. For people with developmental trauma, there's often not before. This is how they're born. This is what their norms are. This is how things should be. And this is about developmental trauma is a chronic exposure to violence, to abuse, and or neglect in early age. Why is it important? Because it's financially costly to our society, and it's one of the most costly public health challenges in the United States. And how it has an impact? It has an impact on the well-being, on the mental and neurological development, and also on medical conditions. And this is lasts throughout life. And when we see people with developmental trauma, we will find them more in the medical units with high blood pressure, with kidneys issues, with cardio issues, allergies, asthma, GI, and a lot of other conditions that are caused by being in chronic stress. The developmental trauma is the elephant in the room. Validity, who was one of the pioneers who correlated the ACE, adverse childhood experience, to adulthood conditions, said, traumatic experiences are often lost in time and concealed by shame, secrecy, and social taboo. And we're talking about people who are coming with present symptoms of anxiety, depression, all this long list that we know. And in the history part, it says that they had a lot of the developmental trauma. But the treatment now is for the current diagnosis and symptoms. And what we would like is to correlate it and treat the cause of the problem. So developmental trauma, according to Hart and Rubia, is severe stressors that produce a cascade of physiological, neurochemical, and hormonal changes, which can lead to enduring alternations in brain structure and brain functioning. And the impact is excessive activity of the limbic system, who lives over here in the back of the head, temporal parietal, and reduced activity of the frontal prefrontal cortex. And if the roles of the prefrontal cortex is to inhibit the activity of the limbic system, it doesn't do its job, and the limbic system can be overactive. And it also means that there's a comparison in the executive functioning, the cognitive behavior and emotion regulation. And this is what the parents described in the testimonies before. This also leads us to the thought that talk therapy who are geared for the prefrontal might reduce their effectiveness because the limbic system is stronger, is faster. And if the limbic system is active, then the cortex, the frontal lobe, is not so active and is not really connected to the back. There might be a comparison in the effect of it. And we would like to go to a therapy who will directly go to the limbic system and will calm it down. And this is the neurofeedback. So let's talk now about the adult and the child studies. We start with the adult studies, and we know that it was the first one that we did in the trauma center because it is easier to conduct than children, even though children are coming first in the age range. And we can summarize it that the results show that for adults with developmental trauma, 24 sessions significantly reduce the PTSD diagnostic and improve the executive functioning, even though we did not directly treat the frontal part. We stayed with T4, P4, which is the back of the head, which is the limbic system. So the study was designed as a random control trial, which consists of 52 individuals with PTSD as inclusion criteria, and they were randomly assigned to either the active neurofeedback group or the control waiting list. And the control waiting list group received the neurofeedback after completing the waiting period. All of them went to 4 assessments or evaluation, and this is equivalent time or sessions for the 2 groups. So the baseline is 2:1. After 12 session, which is half time of the neurofeedback for the active group and 6 weeks for the waiting list, and this is T2. T3 is post-neurofeedback treatment for the active or after 12 weeks for the waiting list, and T4 was 1 month follow-up. We had one protocol of T4, P4, which the rationale was just to calm down the right limbic system. Inhibition was slow activities of 2 to 6 and fast activities of 22 to 36. The rewind started as 10 to 13 hertz and was adjusted if needed based on the arousal and the reports of the participants. It was twice a week for 12 weeks for a total of 24 sessions. The inclusion criteria, as we said, that the participant met the criteria for PTSD, even though we knew that it's compromised the profile of developmental trauma, that most of them do not meet criteria for PTSD. And the exclusion criteria was just to make sure that they are in stable condition, no neurological damages. And the results showed us that after the neurofeedback session, only 27.3% of the active neurofeedback group met criteria for PTSD versus 68.2 from the control waiting list group. We also saw significant improvement in executive functioning. And only one participant reported significant side effects. The adult study was successful, and we saw that neurofeedback significantly improved the functioning of the adults and reduced their symptoms. Our next question was, would neurofeedback have similar effects on children? And moreover, the children's brain is not fully developed, and we were hoping that by doing the neurofeedback for the future, it will help the brain to develop in a better way. So while we were not able to measure in this study the future effect of the developmental of the brain, we were able to see that the 24 sessions of neurofeedback significantly reduced the PTSD symptoms, improved the executive functioning, similarly to the adult study. But because we saw the strength, we added many more assessments for the children, and we saw that neurofeedback significantly reduced the anxiety, depression, dissociation, alexithymia, external and internal behavioral symptoms for the children. So the children, the children in the study were aged 6 to 13. We wanted to expand the profile of the participants so it will fit more of developmental trauma rather than PTSD. So one of the criteria was that they suffered from at least 2 types of trauma, and they had to score significantly clinical symptoms, either on behavioral issues, internalizing or externalizing, or they met the criteria for PTSD. We also required that they will be in a stable condition. The exclusion criteria was to make sure that there are no safety issues. They did not receive prior neurofeedback in the past 5 years, which is very impressive when some of the children were 6 or 7 years old, and they were medically and neurologically stable. The interesting thing about the demographics of the participants was that the major were children who were adopted by upper middle class caregivers. And while we geared for children in inner city Boston school system neighborhoods who lived in stressful places, they were not able to commit to come to the trauma center. And even after, when we offered places to do it in the neighborhood, it was much too much for caregivers who struggle with survival to bring the children twice a week for 3 months. Another interesting fact about the demographics is that 2/3 of the participants were boys and 1/3 were girls. Well, the requirement was that the participants would have at least two types of trauma. We saw that the average was 7 types, which is compatible with the data that once you have one risk factor or trauma, you would have more of it. And not surprisingly, the common trauma were separation, neglect, and impaired caregiver when we're talking about children who were adopted. The study design was similar to the adults. The participants were randomly divided into the active group or the waiting list, and they had the similar 4 timeline assessment. And the waiting list, while they finished the 4 assessment of the waiting list, they started receiving the neurofeedback. The neurofeedback protocol was also similar, with the exception that the reward band was determined as a 3 Hertz band from 1 Hertz below PDR to 1 Hertz above PDR. And PDR is a posterior dominant rhythm that was measured by the highest single band amplitude at CZ with eyes closed. The inhibition were the slow activities and the fast activities. The length of the session, while it was planned for 30 minutes, similarly to the adults, in reality, the sessions were 6 to 12 minutes. Afterwards, the brain was too sensitive and was not able to tolerate a long session. And the neurofeedback training was twice a week for a total of 24 sessions. Assessment, we have behavioral, executive functioning, trauma symptoms, alexithymia, and PTSD criteria. So the results of the study show that the 24 sessions of the neurofeedback training had statistically significantly reduced the behavioral condition, cognition, emotions, trauma, and dissociation, alexithymia symptoms of these children, and also reduce the number of the participants who met the criteria for PTSD. When we would like to go down to the single assessment, we can see in this axis, the x-axis is the timeline. This is the baseline, the endpoint, and the follow-up after 1 month. The y-axis is the score. The green is the active neurofeedback, and the blue is the waiting list. The analysis was based on growth curve modeling, and the comparison was between the baseline and the endpoint, and then the endpoint compared to the follow-up. So we have the 2 curves here. We can see that, interestingly, there was a significant reduction in the active neurofeedback, but there was a regression in between the endpoint and the follow-up. And we can also see that because of the small samples, the waiting list, sometimes the starting point did not match the active neurofeedback. And this was not significant only in one of the assessment. And also, sometimes there was also improvement with the waiting list. It could have been placebo also, and a small number of the participants. So we can see here the differences between the active neurofeedback and the waiting list, and the regression that the active one had, but also in this situation, the waiting list. And these results that we can see in the brief global keep going with all the assessment, with the behavioral regulation, metacognitions, this behavior symptoms, the trauma symptoms, anxiety, depression, arousal, dissociation, and alexithymia. With case studies, we can see that there was a regression with the active neurofeedback, but there was also the regression for the waiting list group, but it was still significant for the active one. And here we can see that the analysis is based on a chi-square, so we have 4 time points. This is, we think, one of the most important results that we had, of course, after getting the significantly reduction. We also have the results that mimic this type of what we had before of the waiting list group, which over there it was the baseline was the waiting list period, and then it was compared to the same client after they got the neurofeedback. So the timeline of T1 to T4 was the baseline, then it was compared to T4, which is the post neurofeedback, and the T7 is the 1 month waiting list. I just have to make sure that this is a very small sample. So we can see here that there was a regression for the children during the waiting list time. There was a huge progress and reduction between the beginning of the neurofeedback to the end of the neurofeedback and the regression of the 1 month follow-up. And this continued again with all the other assessments. So when we look at the caregiver reports at the end of the study, the parents talked about improving in self-regulation in behavior and emotion, but one of them was really interesting. And this is like a mother who reported about her her daughter. And she said that we always spend all the time struggling with her about all these daily things. But now when we don't have to do it, we actually see that she's much more than all these symptoms. She's actually a person. And we can talk about interesting things. We can go to do activities together, something that we were not able to do before. The children, of course, they're not faking it. They're very honest. And when they say that they improve, they improve. And the kids report of a better sleep, a better regulation, a better focusing. They can relax and calm. And this is a especially interesting situation of a child who was, by the 15th session, his high beta was still 25 microvolt, and we were not able to reduce it, both in muscle tension, because we're talking about here, this area, and the high beta. And he had a wonderful practitioner who tried everything, body relaxation, going up and down, trying everything he could, but no help. 15 sessions, high beta suddenly dropped from 25 to 12 microvolt. And the child, when it happens, screamed out and pulled out his electrode and screamed. It's like, you are lying. You lied to me. You told me that I will feel calm and relaxed when it will happen. But you know what? This is wrong, because I felt better before. Now I feel anxious. I feel horrible. I don't want it. I'll never come back to you. And we were like, what was going on? I was relatively new and the practitioner. And then, we were thinking, he was right. That was his baseline. He did not know anything else. And he felt very vulnerable because this anxiety helped him survive. And this child came from a rough background. So the end of the story is that he had a wonderful therapist and supportive caregiver, and we were able to pull it together. And this child made a tremendous progress. A year after, he came back to us and he said, I wanted to go back to neurofeedback. I don't feel calm and relaxed, and I want to do more of it. So when it comes from the children, you know that this is what it is. Another interesting topic that we discovered during the study is that with the children, it did not go smoothly as it went with the adults, and we had a lot of side effects. So we developed a symptom checklist, that we called it, that we asked the caregiver to report after every session. And it was divided into 5 groups: physical, energy, communication, sleep, and mood. And once we started tracking these changes, we saw what was going on, because these kids had a lot of side effects. The brain was very sensitive. And once we saw it, we were able to adjust the protocol. We were able to shorten the sessions. And then we saw that the changes that can go to the side effects, they can also go to the positive side of the improvement, which what we intentionally wanted from the beginning. And you can see the differences between the groups, between the immediate neurofeedback and the delayed or the waiting list group. So what is our takeaway from this study? What we need for a successful treatment is adjustment to the protocol, and it's okay to do it. Normally, it was just enough to change the reward band. And again, it's not that we started with the wrong one, but the brain is changing. People are calming down. So we would like to adjust the reward based on the situation or the condition of the brain. Short neurofeedback sessions. And that was one of the most important takeaways. It's not the longer the session, the better it is. These brains are fragile and sensitive, and longer sessions are causing side effects. Next, 24 sessions might not be enough because we saw the regression in the symptoms between the end of the neurofeedback to the 1 month follow-up. And we also need to track the changes. We gear to do good changes, but we always have to monitor it, and it is our responsibility. Another interesting thing that happened during the session is that the children revealed sensitive information. And as much as we wanted to believe that we're wonderful practitioners, in reality, we did not know why it happens. These kids had wonderful therapists and supportive caregivers. Why was this information revealed to us? And this is our theory, because when we did the neurofeedback here, we calmed down the limbic system and the kids just felt safer to talk about these things that bothered them. So for example, one of the kids talked about suicidal ideation, that he always felt like he's a mosquito on the wall, which everybody wants to crush and he wants to die. And another child said that they don't feel comfortable in their body. And both of these issues were addressed and resolved for the best way. The limitation of this study was that the demographic was not the population we initially geared for, but it taught us a lot about children, even when they come and they have wonderful, supportive, adoptive family, they still suffer from the developmental trauma. It was a pilot study, which means small number of participants and small number of sessions. And also there was a large variability of the types of the trauma, the age of the trauma, and the large age range of the participants. Child who is 6 years old is not in the same development level as a 13 years old. That's a huge difference between them. We also had multiple inclusion criteria, which we wanted to fit more for the developmental trauma, but we also knew that it's going to weaken the strength of the research. Another big issue is the one protocol that was independent of symptoms and qEEG. The challenges that we had when we did the study were initially the children were treatment resistant. So they already came to us after all the many other options that they had. And it was not easy because the kids are like, no, I don't want to be here. I want to do something else in my time after school. Another challenge that we had was the children who did not have emotions start expressing emotion, for example, sadness. And while this is a huge progress for clinical aspect, it's considered as something worse score in the research assessment. But we were very happy that it happened. And even with this, we still got the significantly improved results. We had a bunch of practical challenges. The kids did not want to come. They were very sensitive and did not trust us for placing the electrodes physically on the head. So we worked with them, they did it together. And again, it was challenging for the kids to sit still on the table. So finally, you were able to place the electrode, get the right impedance. You turn your head for 1 second, push the start button, you stop the recording, you go back, the electrodes are out. But over time, things gotten so much better. We also had to find ways to engage the children, and that's we did by secondary reward. And this was a huge industry of, we saw the progress of kids of having, taking small prizes that were based on the neurofeedback score points that they got, all the way to the end that they were able to calculate and save them and get bigger and more valuable prizes. So if the training was 6 minutes, the rest of the 24 minutes or 45 minutes were spent on the industry of the prizes. And the last thing, that it is important to track changes. It is our responsibility. Sorry. This brings me to the side effects. Side effects are happening to every treatment modality, including neurofeedback, and we don't have to worry about it. Side effects are can be general to the neurofeedback, and this is like the brain gets tired. Sometimes watching the screen for a long time can cause headache. They can also be specific to the protocol and the clients. The good news for us that these side effects are transient and mild and can be addressed and mitigate if we do something about it. But again, it's our responsibility. What can we do about it? We can track the changes, we can adjust the protocol, we can shorten the sessions, and there are probably more things to do. So the future challenges for us is to understand how training the back of the head improve the executive functioning in the front. Is it network effect? Probably yes. We would like to prove it. Also, as much as the symptoms significantly reduce, they're still there, and we would like to keep reducing them. One of the main things that we think is to have an individual protocol that is based on their symptoms and or brain mapping. Analysis, we would like to have more ways to analyze the data rather than the regular analysis of pre-post of absolute value, relatively value, group analysis ones. And finally, we would like to have enough data to be able to detect neuromarkers that will predict the effectiveness of the treatment. So the point that I would like to talk about here is that we were able to define a significant improvement in the subjective measurement. However, when we did the qEEG, we found the changes in the individual level, not in the group level. And this is because of probably the huge variability of the locations, the frequencies, the types of the measurements, and we had a small sample. So what we would like here to invite people who are doing different type of analysis to show us that this can be done and we can see the changes in the EEG that is accompanied the changes in the questionnaires, which is subjective. Two examples here of changes, and this is with Annie, who not surprisingly had issues in school with focusing, and this is the reduction of the theta that she had here. Or Shelley, who also in this situation is in the theta, but also the coherence was changed. So the takeaway for me and the invitation is we need collaboration between clinicians to collect a lot of data, so we'll be able to give it to the researchers to analyze it, to have neuromarkers, to improve the effectiveness of the treatment, and the engineer who will develop systems that will be gel-free, wireless, and more variability in the feedback process that we have, and in affordable cost. So thank you, and we're always happy to collaborate. We're happy to give you our symptom checklist or to answer any questions.